All right, why don't we get started? Good morning, good evening, everyone. Uh, Welcome to today's expert community podcast. Our guest is Dr. Samir Melankari, and we are going to get into it with him. It's going to be quite an exciting session. So, before that, let me quickly cover the usual things. We will make sure to answer any questions you may have. So, please keep typing them away in the chat window, and we'll get to them at the end. Uh, if you're not already a member of the Longevity Circle, please join it. It's free and it's got a lot of interesting guests, and you get your questions answered. The link to the community is going to be put by Sneha in the comment section. So just click on that. Uh, One of the things that we've started about 3-4 weeks back is we have Dr. Saurabh Sani doing a free 15-minute session every Wednesday. It's a physiotherapy session, only 15 minutes, 8:30 in the morning Pacific time, 9 o'clock in the night India time, where he picks one topic, and the ones I've bolded on the screen are the ones that he's covered. Videos of those sessions are in the community. So if you miss the live session, you can watch the recording a couple of days later. Those sessions have been excellent, lots of participation, and you get to ask questions as well if there's anything that isn't clear. But the exercises he provides are very simple, easy to do, and it's definitely worth attending. Our speaker for next week is Dr. Rashida Melankari, who many of you have known and interacted with. And so this April, we begin with the Melankaris. And so Rashida will be talking about everything to do with cholesterol, heart health, and effectively all lipids. And so on to today's guest, it's Dr. Samir Melankari. And while his profile, his resume is very, very long, I tried to capture it in very short on this slide. I don't think it does it justice to what all he has accomplished. But most importantly, he's a doctor that is very, very well regarded, very well respected in the world of hematology. And there are just so many different topics to cover that I will be surprised if we can get through all of it today, but at least we'll get started. And so without further ado, Samir, welcome to the community podcast.
Yeah, thanks, Nikhil. Thank you for hosting me on this platform. Pleasure to join.
Yeah, lovely. So, Samir, why don't we get straight into the basics? I mean, we know blood is an important part, but most of us don't think about it on a day-to-day basis, what our blood is doing for us. And so maybe it would help, Samir, by starting to talk about the basics of blood. What is the role it plays in our bodies?
Sure. So blood, as you know, is a liquid connective tissue. It connects various organs, but the blood is formed inside an organ called as the bone marrow. As we know, it's like a jelly-like substance that is present in your bones, generally in the flat bones, your ribs, your sternum, your skull, your pelvis. These are the bones which contain active marrow, not the long bones like your femur and tibia, etc. This organ is the largest organ of the body, actually. It's actually the largest. It's very difficult to quantify it because it's in various places, but it's jelly-like, so it's actually the biggest organ. And more importantly, it's a fascinating organ because each day, there are stem cells inside the bone marrow which produce the blood cells, which are the red blood cells, the white blood cells, and the platelets. And can you imagine how many cells are produced each day? In one day, you have about 100 billion white blood cells being produced, about 200 billion red blood cells, and about 400 billion platelets that are produced each day from the bone marrow. So it's like a factory, which I don't know whether there's any other, production house that can produce so many cells in one day. But the role of the blood is most important. Number one role is to the red blood cells contain hemoglobin, which provides oxygen, catches oxygen from the lungs and provides it to the various organs. That's the number one function. The second is the white blood cells, which provide immunity. all the germs, microbes are going to attack you is going to be taken care of by the white blood cells. And third important function would be that it's a, it's an organ where, all the organs are interconnected via the blood, right? So if your pancreas needs to secrete insulin, and that insulin has to go everywhere else, it goes through the blood. So it's a mediator of, it connects between all these organs. So that's called as a liquid connective tissue. So that's in brief about the blood.
Sorry, it's fascinating, Samir, that those numbers you described. Uh, I had never heard those numbers before, and we think we understand our blood. What a factory! What an efficient factory! And in this efficient factory, the other thing that I've heard is that, and you can help correct if this perception is right or wrong, is that those blood vessels that are carrying all of this are tens of thousands of kilometers in.
Yeah.
Is that true?
Yes, it is true. In fact, it is said that, if you open the capillaries of the lungs, both the lungs together, and open them out and roll them out and just, flatten them out, they would cover a football field.
Wow.
Yeah, that's the number of capillaries that are there in the lungs itself. And then you can imagine through the rest of the body how much they would cover.
Yeah, that's fascinating. And the other thing that I've also read somewhere, that the heart is pumping about 5 liters of blood per minute. That's a lot of pumping that's happening, right? Of this liquid through
Yes.
our bodies.
Yes, and for about 70 odd years.
For 70 odd years.
Amazing. It's amazing.
So
Never tiring
with that as a background, I mean, I think that is already quite insightful for the common man like us to know. And then the blood itself, Samir, it feels liquidy, but there is stuff in it. So can you describe the composition of blood?
Blood has the cells and the fluid part of it. The cells is the solid part of it, and the fluid part of it will be, is plasma, right? So plasma is something that contains water predominantly. Most of it is water, and it also contains various proteins. The plasma proteins, there's albumin, globulins, fibrinogen. These are all various plasma proteins that constitute the plasma. The clotting factors of the blood are present in the plasma. Right? So the two basic components.
Got it. And so one of the things that I remember reading once, that humans have red blood, whereas some animals have blue blood. And the difference is iron versus some other mineral that chemical that they have, right?
Yeah. I mean, the hemoglobin would be completely different in humans versus some other insects. For example, you may have green blood, blue blood, whatever. I'm not an entomologist, so I'm not very sure about which organ insect contains what kind of blood. But yes, you're right. The requirement of oxygen is very different, so some animals require a lot of oxygen. Some of them don't require much of oxygen. It's very little. So that's the way, it's different, and the color of the blood will be completely different.
Yeah. And so, given that that's sort of the basics, it's not a surprise then that every now and then this factory can have issues when it's working so hard. So what are the most common problems, Samir, that one sees or you see when it comes to the blood?
So we could maybe classify that as something that is seen in somebody who is apparently completely normal versus somebody who is actually ill, right? So if you ask me, what do I see in a day-to-day practice where, which is seen in otherwise seemingly normal people, then I would say that number one is an iron deficient state, right? So there is anemia when that iron is a component of hemoglobin, and iron, without iron, if you don't have iron, hemoglobin is not going to be formed properly, and therefore iron deficiency leads to anemia. That's decrease in the hemoglobin. But there is a state which what people don't know is you could have a normal hemoglobin, but you could still have low iron stores. So you're eating a nutritionally poor diet, or you're bleeding a little more, and that causes loss of iron, and you're on very borderline iron stores. So, for example, currently there's a lot of LPG shortage all over the country. So similarly, and you're living on very low reserves. Similarly, your iron is just about adequate to form the blood, but it is not adequate for all the other tissue functions, and that leads to a lot of symptoms. For example, you may have a hemoglobin that's 12, but your iron is low and you feel extremely fatigued. There's loss of energy. There's in children there is scholastic backwardness. They're not able to focus properly. A lot of physical and mental intolerance, irritability, perceiving excessive pain. So all these symptoms, hair fall, very common. These are all symptoms which you don't know what the reason is, but then when you actually look at your iron stores, there's a blood test called serum ferritin. If the ferritin is low, then that will indicate that your iron stores are low. And unless you correct that, you're not going to get relieved of the symptoms. So that's one thing that's probably one of the commonest things that I would see in a normal person. And
Samir,
then
before you go on, can I ask a couple of questions? Because I think you have highlighted something that I don't think most of us, when we see some of these symptoms, first think of iron being the issue. We think of lots of other things being the issue. So a question on that. Is the primary source of iron for us food, or are there other sources?
There is only one source, and that is the food.
So the
Iron
body
is
is
not
not
produced
making iron
in
on
your
its own.
body. It
It's
doesn't. It
constant.
doesn't make iron. It doesn't make iron. It just you have to eat it from your food.
Okay. And the primary sources are like things like spinach. What are the things that you would recommend?
Okay, so the richest source of iron, I would say, is the meats, the red meats. I'm not promoting non-vegetarianism here, okay? But just on a scientific, if you look at it scientifically, the meats will have the highest amount of iron. In the vegetarian sources, you have the green leafy vegetables, the red leafy vegetables, the fruits, nuts, pulses. There are the pulses have a good amount of iron, and other things like ragi, etc., dates. These are some things which contain iron. What doesn't contain iron is what is often eaten much more. Okay, and that is, so eggs do have zero iron. Milk and milk products, no iron. Okay, and unless fortified, your atta, your wheat and rice has very little iron. So people tend to eat they have milk, they have milk products, they'll have a lot of the chapati, but very little vegetable. That typically leads to iron deficiency.
Got it. Yeah. All right. So iron, you pointed out as being the first of the issues.
Yes. Yeah. So iron is the commonest issue. The other thing that I would like that I want to mention is a condition called thalassemia. A condition called thalassemia trait. And what is thalassemia trait? And this is actually pretty important, and everybody should kind of know it, because any one of us could be having it. 1 in 100 people approximately in India would have a thalassemia trait. So what is it? So in every cell there are two copies of genes which produce any protein, right? So hemoglobin is a protein, and it is produced from two genes, one which comes from the father, one which comes from the mother, and normally both these genes are functioning. If one of the genes is not functioning properly, that means it is either not producing hemoglobin at all, or it is producing a defective hemoglobin. Then you have a condition called as a hemoglobinopathy. Okay, now if one gene is abnormal, the other gene can compensate overfunction and produce reasonable amount of hemoglobin. So hemoglobin may actually be completely normal. You may be having a hemoglobin of 14 grams, but you could still have something called thalassemia trait. Now, what's the implication of this? So most people will not live and die without knowing that they ever had this condition. Most people. It's only during illnesses or during pregnancy that when you're put at stress, the hemoglobin drops down transiently. Again, once that illness goes away, your hemoglobin goes up. So most people are asymptomatic. The problem comes when two individuals who have thalassemia trait or minor get married to each other. Okay, they won't know that they have it. If they get married to each other, And if the child randomly picks up one gene from the father, one gene from the mother, and is born. So he may be born with both normal genes, one abnormal, one normal gene, or a 25% chance that he may pick up both the abnormal genes. If he picks up both the abnormal genes, then he becomes thalassemia major. He has no capacity to produce hemoglobin, and he is dependent on transfusions, blood transfusions every month, right from the child, from the time he's born. So that's a bad situation, and this is something which must be picked up not by the patients, actually by the doctors, because it's difficult to educate patients about this. But doctors must be educated a lot at that, how you can actually pick up this thalassemia from by looking at a routine hemogram. A hemogram is a complete blood count which shows you the red blood cells, the white blood cells, the indices, meaning how big or small these cells are, what their content looks like. So all that can be, it's a bird's eye view where a physician or any doctor should be able to look at it and give an idea as to how to pick up a thalassemia trait. Maybe we can come to it further if you have time in this talk. So that's something very important. And what's important is if two thalassemia traits are picked up when they're married, okay, you can prevent the birth of a thalassemia major baby by looking at checking the DNA of the baby right in the 10th week of pregnancy, and you can identify whether the child has thalassemia major, and then you abort the pregnancy. So that's very important for gynecologists to pick up. So that's the second most important thing that I would see in a otherwise normal person.
And Samir, for the baby that's born with thalassemia major,
Yeah.
is there right now nothing other than a monthly transfusion for the rest of its life?
Oh no, there is bone marrow transplant which cures a good number of these patients, and now there is something called gene therapy, which is approved for thalassemia, and patients can be cured. But it's a bigger topic. Maybe we can discuss it later. But
Yes.
yes, so these are two treatments which are available for thalassemics currently, but they're not. It's difficult for every patient to go through this therapy. So we have a lot of children who end up just taking regular blood transfusions.
All right.
Okay, so the other thing that is commonly seen is a thrombocytopenia, platelets being low, and that's another common something which patients get petrified by. They get very frightened when they see that the platelets are low. Many people associate it with dengue because everybody in dengue develops platelets drop down, but that's a very transient thing, and it doesn't mean much. It just goes back to normal very soon. But chronically having low platelets also a very common condition. Now, interestingly, there are some populations, for example, the Bengalis and the Kashmiris. Actually, most people don't know about the Kashmiris, but Kashmiris and Bengalis have very large size platelets right from birth. They're normal platelets, they're large in size, and the machine, the cell counter which counts these platelets actually won't count these platelets because they're large in size, and therefore it will give a artificially low platelet count. So that's a common reason why they're low. And the other situation is where your own white blood cells, there's a category of diseases called autoimmune diseases, where your white blood cells by mistake decides to attack a part of your own blood cell or a part of your own body, thinking it is a foreign germ, and starts attacking it. So commonly the white cells destroy the platelets, so their numbers come down, and this is can be present chronically, but as long as it's not very low, it doesn't require treatment. You don't tend to bleed with a slightly low platelet count. Another thing that is interesting is, most people look at low hemoglobin, where everybody knows a little bit about anemia. But what people don't know is that a normal person could have a high hemoglobin. And a high hemoglobin is also risky to have because it can increase the viscosity of the blood and lead to thrombosis. It can actually, you can have clotting of the blood if you have a high hemoglobin. So, the normal hemoglobin for a male is more than between 13 grams to 16.5. For a female, it's 12 to 16. Okay, below and above that is anemia and polycythemia. So if your hemoglobin starts to cross 18 grams, then your risk of clotting significantly increases. So you should be aware of this. So a high hemoglobin can be seen in people who have, one is sometimes they have certain activating mutations in the red blood, in the stem cells. So that's why they start producing more and more red blood cells. So chronic, it could be seen when there is hypoxia. If you're a chronic smoker or if you have this obstructive sleep apnea, where you have, a lot of fat on your neck, and when you sleep, you start snoring because the fat just, compresses your trachea. And then you have these hypoxic spells at night, and during that period, there's less oxygen that's provided to the blood, and so the bone marrow perceives it as hypoxia and starts producing more and more red blood cells and more hemoglobin to compensate for that hypoxia, and then that leads to a chronically high hemoglobin. And sometimes, people who have a lot of stress, something very under-recognized cause of polycythemia is stress polycythemia. A lot of people who have this, type A personality, or, a short-tempered, a very anxious person, their hemoglobin tends to increase by certain hormones. And if you're drinking chronically less fluids, you get the water content of the blood increases, so the cells get concentrated. So you have, and this is particularly seen in alcoholics. If you have somebody who's drinking daily alcohol, the alcohol also dehydrates the blood. So, you get this chronic hemoconcentration that leads to a high hemoglobin. So these are, important things that one must know, because if they're not treated correctly, then they lead to consequences. So I would say these are some of the common things that I see in a otherwise normal person.
It's quite insightful. I mean, some of these things that you just spoke about, I don't think most of us think about. Like, for example, the fact that stress, people always talk about stress as a very qualitative thing. But given what you just said, it actually does show up quantitatively in certain markers. And we might look at it and say, oh, it's because of this reason or that reason, but it could be because of stress. And that in itself is something that we will all keep a lookout for, given what you just said.
Yeah, stress is something which, there are a lot of people who have stress. Politicians have a lot of stress, etc. But, they are used, the way you absorb that stress and, assimilate that stress is important. So you have stress, but you can deal with it, then your hemoglobin is going to be normal. But if you have stress and you're unduly anxious about it, then the hemoglobin is going to go up.
Yeah. And this is all, and right now, all you've spoken about is primarily otherwise normal people, healthy people.
Yes.
Right?
Yes.
There's a whole list of things that impact people that become unhealthy because of their blood, right? And that's maybe
Absolutely.
the next topic for us to talk about. But even in the list of things that healthy people get impacted by, is the best way to catch all of this, Samir, through regular blood tests, or are there other ways that one can figure out without doing a blood test?
No, all of these that I mentioned, you will have to have a blood test to diagnose it. Otherwise, it's very difficult to, somebody comes to you with fatigue, etc. There's hundreds of causes of, having that, including just mental fatigue. So, unless you do an appropriate blood test, you're not going to be able to diagnose it.
And the parameters, Samir, that are typically measured in the regular blood test, those are good enough, right? Or are there some special parameters or markers that you'd recommend?
You just start off with a basic hemogram, and depending upon the patient's symptoms and what you see in the hemogram, you can then advise appropriate tests. So, for example, if you see somebody who's got small red blood cells, then the small red blood cells are seen typically in iron deficiency anemia and thalassemia. So you get a clue that this could be the cause. Then do an appropriate test for thalassemia, look at the ferritin levels, you diagnose iron deficiency anemia and thalassemia, things like that. So the hemogram gives you a good clue. And then, of course, there's a physical examination that you would actually need to see the patient to identify certain other signs, and then arrive at the correct diagnosis.
Got it. And would you put HbA1c, which is a marker everybody seems to become very familiar with, as something, because people can be pre-diabetic.
Yeah.
And is that something that you would put in the healthy people or unhealthy people? Because that sort of can cross the barrier, right? If I'm pre-diabetic versus diabetic, how do you think about that, Samir?
So diabetes is actually a non-hematological topic. It's something which probably Rashida would deal with better, or a physician or a diabetologist would deal with better. But it is, A1C has nothing to do with the blood per se. Although it's a blood test, it has nothing to do with with the blood disease per se. A1C, of course, I mean, if you're but what would happen is that if you, the only relation between the blood and A1C would be that if you have a severe anemia, then your A1C would be falsely normal. You may be a diabetic, but if you have less hemoglobin in the first place, then your A1C is going to be falsely low. That's the only link that I can tell you about.
Got it. Isn't there also something about uh, while it's a 90-day average, certain maybe the red blood their lifetime is less than that. Does that I read that that can potentially change the interpretation of A1C. Is that true?
Yes. So shortening of the lifespan of red blood cells would mean anemia, and once you have anemia, obviously your hemoglobin is going to drop and your A1C is going to drop.
Got it. Got it. Makes sense. Let's, Samir, talk about the more the types of issues that happen in unhealthy people when it comes to blood.
Sure. Nikhil, is my voice very clear, or is there an echo or something?
There was
I
an
just got
echo
a
in the
message that there's
middle.
an echo. Okay.
If everyone can just go on mute, and I'll do that as well when you're speaking, Samir.
Okay. Okay. Fine. All right. So, well, the diseases of the blood, would commonly be iron deficiency anemia that I just mentioned. That's the commonest anemia that one would see. About 30% of women in the world are iron deficient, commonly because they are nutritionally depleted. Second commonest is because they have, because they're menstruating, you have blood loss. So they're commonly depleted. Men also, if you have inadequate iron-rich diet, you're going to have iron deficiency anemia, and that needs to be corrected. Now, the other commonest cause of anemia that one would see is called megaloblastic anemia, and that is because of deficiency of vitamin B12 and folic acid, because these are also required for production of blood cells. If both these are deficient, then your red blood cells are affected the most, followed by the white blood cells and also the platelets. All these blood cells will go down if you have these deficiencies. So that's the second most important cause. Now, um, let me ask you, do you know what the dietary source of vitamin B12 is?
Dietary source of vitamin B12. Is it again like fish and greens?
Yeah. So how would vegetarians get it? Okay,
I
let me
think that's
answer.
the
Let me
reason why
answer the
so many
question.
vegetarians are vitamin B12 deficient.
Let me answer that question. It's a little interesting. That's why I thought I'll tell you about this. So, vitamin B12, which is produced in nature by certain bacteria and some fungi. It's only produced by bacteria and fungi. So the herbivorous animals, when they are grazing and then they're eating their plants and the leaves and all, the whatever microbes contaminate these leaves, they would ingest them and get their B12 from those bacteria. And then the carnivorous animals would eat the herbivorous animals and derive their B12 from the meat of the herbivorous animals. Okay. So humans and no animal produces, or even a plant. Plant doesn't require B12, but animals and humans don't produce B12 themselves. They have to get it from these microbes. Okay. So either a human eats a non-vegetarian food from which he derives the B12 from the meat of that non-vegetarian food, or you have to, so the milk contains B12 because B12 is passed in breast milk. So if the cow which has the B12, when it would pass it in the milk, and you would be able to consume milk, and that's only the probably the only vegetarian source of B12. But the problem is, if you want to have your daily requirement of B12 through your milk, you would have to consume something like 500 ml of milk in a day. Okay, now your one cup of coffee or one cup of tea is not going to be able to give you that. Even somebody who loves milk would generally have about 200 ml maybe of milk once. You can't have 250 ml of or 300 ml, or let alone 500 ml of milk every day. So milk, curds, cheese, milk products would have a certain amount of B12, but often you don't consume enough because nobody tends to eat, and vegans surely not. Then the other thing that you need to do actually, which is not optimal, is not ideal, but and you can't prescribe, is that you need to eat a little bit of contaminated food, because you need to get your B12 through your bacteria and some fungi, right? So now I can't tell my patient who's vitamin B12 deficient, go and have some contaminated pani puri and get your B12 from there. Okay, he'll get a diarrhea and come back to me cursing me. So I can't tell him, go and have bel puri. Oh, so what I have to tell him is that, eat some raw food. So when you eat raw salads, fruits, nuts, some contaminated bacteria that are lying. Even if you cook the food, you're going to kill the bacteria. You don't kill B12. B12 doesn't get destroyed by cooking food. But if you cook it, the bacteria will die, and you won't get that B12 from there. So eat a lot of raw food. So a little bit of bacteria that contaminated, you can get your B12 from there. And others, if you're a strict vegan, then you would have to have supplements. Without supplements, you're going to get B12 deficient. Also, people say, he's a, that Indian, that he's a non-vegetarian. How can he have B12 deficiency? The problem is, commonly, Indian non-vegetarians are, they have meat once a week. Some 3-4 pieces of chicken once a week is not going to give you enough of B12. you know that's why, when you check, many of us are actually vitamin B12 deficient, because you just don't consume enough.
Yeah.
So that's megaloblastic anemia. The other thing is folic acid. Folic acid is also intertwined with vitamin B12, and together they work together to produce the nucleus of these cells. And if that is deficient, and folic acid is omnipresent, present in a lot of foodstuffs. So unless you're really ill and not eating anything, you won't have folic acid deficiency. So that's about megaloblastic and vitamin B12 deficiency anemia. So the other most sinister causes of anemia is where your bone marrow has stopped functioning. It's not producing enough of red blood cells. These could be, genetic causes like thalassemia and sickle cell anemia, or many others. You could be lysing your cells. Red blood cells are deficient in a particular compound that compromises the stability of the red blood cell, and they just break up. Or you could have a genetic dysfunction that develops in your stem cells. They start producing, there's a mutation in the stem cells. They start producing defective quality of red cells or white cells or platelets, and that's called myelodysplastic syndrome, where bad blood is quality of blood is produced. Sometimes your white cells will destroy the red blood cells, like it's an autoimmune hemolytic anemia. Or the white blood cells, they start attacking your own stem cells. In that case, you have no cells being produced. That's called aplastic anemia, where no cells are being produced. It's an autoimmune disorder against your own stem cells. These are some of the sinister causes of anemia. And then, of course, there's a huge category of blood cancers, blood cancers which cause a decrease in the output of all these blood cells. So these are all these sinister causes of anemia, I would say.
Wow. All of this is happening inside our bodies, and we sort of take it for granted until something happens.
Yeah.
B12, like you said, is one big deficiency, Samir, and I think this 80% of the people seem to have a B12 deficiency. Just anecdotally, when we look at so many reports, and similar thing can be said about vitamin D3. Right? That's another one that seems to be always deficient in blood test reports.
Yeah, that's true. It's real odd. Sometimes I just don't know how to interpret those blood reports, because every now and then you have patients who are coming with this. But it is equally true that the vitamin D, of course, is derived from sunlight, who goes in the sunlight nowadays? How many of us? I know that I need to go in sunlight, but where's the time to go in sunlight? And where's the time to take off your shirt and jog and in the sunlight? So I don't have time for that. So I'm chronically inside the hospital, or in my house, or in an air-conditioned car, and I don't have exposure to sunlight. It's very common.
Yeah. So when it comes to lifestyle, Samir, I mean, you just gave an example of that. You know what the right thing to do is, but practically you don't have the time to go out and get your vitamin D3 up through sunlight. What some of the habits that you recommend to patients? I mean, there's of course medication that can be given, but from a pure lifestyle perspective, what are in your mind some absolute must-dos where possible, whether it's diet or exercise or sleep or stress? Do you have a sort of list of things that you always recommend?
Okay, so it's an important thing that so diet is the most important. I just mentioned the diet, the diet, and I have nothing to add beyond that, because the only two nutrients that are required for good blood formation is are iron, vitamin B12, and folic acid. There's other than that, there are very few, copper, and some other elements are there, but which you would need. But you generally, if you're having a reasonable diet, you would get these through your diet. So diet is clearly related to a good hemoglobin. Diet does not change your white blood cell count or your platelet count. So people who come to me with a low platelet count, with the immune thrombocytopenias, or thrombocytopenias low platelet count, or various other reasons, they keep asking me, okay, doctor, what diet can I eat to improve my platelet count? So there is no such diet. People eat a lot of fruits, kiwi and dragon fruit, and the papaya leaf extract has some sense in it, but that's again for a very transient reason, and only for a specific immunologically mediated drop in platelets. There is some evidence, although it's not strong enough to recommend, that papaya leaf extract can increase the platelet count, but eating papayas or eating any fruit is not going to improve your platelet count, not your white cell count. So that's about diet and other blood cells. And regarding exercise, regarding exercise, exercise has no effect on the blood cells. Okay, exercise has a positive effect on a lot of things in our, on heart health, on whatever lung health, etc., etc., muscles. So I mean, there's no, I don't need to stress how important exercise is, but exercise has no impact on your blood cells. If after a lot of exertion you check your CBC, your complete blood count, you'll see a slight elevation of the white blood cell count, but that's again very transient. Otherwise, it has no impact on the blood cells. And sleep, well, sleep has again no impact on the blood per se, but if you don't have a good sleep, and then your hemoglobin can actually start going up, as what I mentioned about the stress polycythemia part of it. Inadequate sleep would probably lead to, because of stress, or because of these hypoxic events or whatever, it might just lead to a slightly high hemoglobin. But other than that, sleep has no impact on the blood per se.
And so,
Another
hydration.
interesting thing I will tell you, Nikhil, is that the blood cancers. We know that a lot of poor habits, bad habits, like smoking and alcohol, lead to so many other cancers, right? But blood cancers, very funnily, most of my patients are actually complete teetotalers,
Hmm.
most of them. So it has, having a healthy lifestyle, absolutely healthy lifestyle, marathoning, athletic, athletes, etc., are prone to blood cancer just like anybody else who's a smoker and drinker would be. Okay, I'm not promoting smoking and drinking here, but I can assure you that it's got nothing to do with addictions and lifestyle. Blood cancers just strike from the blue sky, and they can just happen to anybody. You're just trying to develop, you develop it.
Yeah, that I think that's a concept. Last time we had a cancer expert talk, and I think the take
Yeah.
on that was, in most other cancers apart from blood cancer, lifestyle reduces the probability. Right? A good lifestyle reduces the probability of it happening, but cancer, heart disease are fundamentally sort of probabilistic things. There's always a chance. You just try to reduce that chance. But it sounds like in blood cancer, that's not even the case, that it's completely random.
Yeah.
Um, how about hydration, Samir? Does it provide long-term benefit, or is it day to day? Like if I hydrate well today, I'll be good, and tomorrow is a problem. What is your take on hydration?
Hydration is very important. Hydration is very important because if you are underhydrated, you get hemoconcentration. The blood gets concentrated. It's going to flow more slowly, and it can clot. It can lead to a high hemoglobin. So hydration is absolutely essential to prevent clotting of blood.
Hmm.
That's what I would talk about hydration.
Got it. I'm right after this podcast, I'm supposed to go for my blood test, and I
Yeah.
have to remember to drink enough water before I go for the blood test. Because I imagine, given what you just said, Samir, the blood test results could vary if you're well hydrated versus you're not well hydrated, right?
Yeah. Yeah, they could vary. So if you do it in a in a underhydrated state, then you're going to have increase in your artificial increase in your hemoglobin. Yeah.
Right, right. One other thing that you mentioned a couple of times was about hypoxia and the impact. And I imagine because of that reason, uh, people who are living at very high elevations,
Yes.
the way their blood composition is different than a year later they come and start living more on the at the plains.
Correct. Correct. That is true. That is true.
I mean, in many ways, that's also, I guess, the reason why a lot of athletes very often train in high altitudes, right? I think it sort of probably helps for the reasons you mentioned earlier.
Yes. So, training in high altitude is probably a completely different thing. Of course, you can you can train now in a hypoxic chamber also. In
Yes.
our hospital, we've got a built clinic where you've got a hypoxia chamber. And if you want to go to a high altitude, then you can do that. Otherwise, I don't see the benefit of training at a high altitude unless you're going to be a soldier or a mountaineer.
Hmm.
Then only you need to do. Otherwise, in routine life, I don't think there's any added benefit
Right,
of training there.
right, right. Um, let's move to some of the more futuristic things, because there's a lot happening in this space. Samir, I know that you followed it closely, and I'd love for the community to hear about some of the things. I mean, we've heard about things that have been happening for a while, like bone marrow transplants. Now that is a little bit more commonplace, but this whole CAR T therapy, genetic, gene therapy around various issues in blood cancer and other cancers. Uh, can you talk about what is happening in this new world that's evolving fast?
What would you like me to talk about first? Do you want me to tell you about what is a bone marrow transplant
Let's
or
start from that and
that's
then.
not okay? Okay, fine. So you have various blood. What are the disorders of the blood? I just to enlist some of them. The blood cancers, which is leukemias, your lymphomas, which are blood cancers of the lymphocytes. You have multiple myeloma, which is a cancer of the plasma cells. These are various types of blood cancers. You have bone marrow failures that I just described. You have a lot of immunodeficiency disorders that are present from birth. You have these hemolytic anemias, the sickle cell anemia, thalassemia. These are kind of common blood disorders. Now, if you want to treat these, one of the methods is that you just change the blood, right? You just change the blood. Suppose you have a kidney that is damaged, you operate, take out that kidney, put a healthy donor's kidney in, and then your job is done. But how do you change the blood, which is a liquid connective tissue, right? So the way you do it is that you have these stem cells from which all the blood cells are formed, and your job is to change the stem cells. Now, how are you going to do that? So what is done is that the patient who has the a particular disease, whatever the blood disease is, he is admitted in a room which is bacteria free room. It's a HEPA filtered room, just like your operation theaters, etc. And in that sterile environment, he is delivered chemotherapy or radiation to the bone marrow to destroy that bone marrow. Okay, you wipe out the bad bone marrow, and then you have to extract the donor's stem cells. So how you extract it is that the donor goes on to a machine in the blood bank. Okay, he doesn't get admitted. He just walks in, goes to the blood bank, sits on a machine. His blood moves inside the machine from one side and comes out from the other side and comes back to him, just like a dialysis. And the machine is called as an apheresis machine, and that machine is primed to extract any blood cell that you want. Okay, so you can extract the stem cells from there and collect it in a bag. Okay, and the donor's job is done. He's free. So he just walks in, just like a platelet donation, and walks out. And those stem cells are collected in a pouch, and they are infused into that the patient's blood, the bone marrow of whom is destroyed. You infuse them into the blood. The stem cells know where to go. They have adhesion receptors. They'll go into the bone marrow, find their niches, attach there, and start producing new blood. One stem cell can form 1,000 more stem cells, and then they start producing the new blood. whatever the patient's blood group is, it changes over to the donor's blood group. And it takes about 2 or 3 weeks for that new blood to form in the patient. While that during that period he is completely immunocompromised, he has no blood in him. You have to keep transfusing him, handling his infections, handling various complications, etc. And once the donor cells engraft, he has normal blood. And then, of course, it's a very simplified thing, but there are a lot of complications that can happen if the donor cells decide, no, this is not a good body, I need to attack it. It'll start attacking the body. You need to calm it down. The body, the patient's body may say, you may reject the stem cells, the incoming cells, may not like it, he may reject it. So a lot of other complications, some autoimmune complications may happen. And all of these have to be carefully handled for the next 6 months or so. But if it is successful, then the patient has a completely normal life. And a good number of blood is, if you have a thalassemia or a sickle cell anemia, the chance of a cure with a stem cell transplant is about 80 to 90%. Whereas if you have a bad blood cancer, etc., your chance of cure is somewhere around 40 to 50%. So it varies on what disease you have. The other way of extracting the stem cells of the blood is to directly take them from the bone marrow. You take the patient in, that used to be the older technique, where you take the patient in the operation theater, the donor in the operation theater, and put him upside down. And from his iliac bones, you stick in needles and extract the marrow from there. From an adult, you may have to extract about 1 liter of bone marrow, and that is collected in a bag, and that marrow in the bag is infused into the blood of the recipient. There again, there's no surgery involved. It's just a very simple procedure. But of course, what you do after that, how you handle the patient after that is all very important. So that's about. And now, interestingly, who can be a donor? You can be a donor if you have a tissue identical, if your tissue matched with the recipient. So your HLA result, just like you have your blood groups on your red blood cells, on the tissues you have an HLA group. The HLA group has to be similar, or at least half similar. So that similarity can be found only from a sibling generally. If you look in the general population for a HLA identical donor, you have to screen 10,000 people to find one person who is HLA identical. So it has to be a family donor most of the times. But then there are several lakhs and millions of voluntary stem cell donors whose HLAs are stored in various registries. So if I want to check for an unrelated donor, I just go online and search for an unrelated donor, deal with that registry, and the donor who is who may be in a different country will donate his stem cells by apheresis technique over there. They'll be transported to my center, and those will be infused into the blood of the patient. So these are called unrelated donor transplant. All these things are pretty common. We do them routinely now. That's about a bone marrow transplant.
As you were saying this, I was thinking to myself, when it was first designed, this whole approach, it must have been quite a difficult task to convince people, let's do this, and with all the possible complications that can arise. But the fact is, has happened, and that sort of speaks to the innovation that's happened in the health space.
Yeah, in a couple of minutes, I'll tell you the interesting part of it. So, the gentleman by the name of E. Donald Thomas, he from the US, from Fred Hutchinson Cancer Center, he's the person who did the first experiments for bone marrow transplant, in dogs first in the early 1960s, and then subsequently in 1960 actually realized that this is what can be done. And subsequently in 1990, this work was recognized, and he received the Nobel Prize. And he received it along with Joseph Murray, who received the Nobel Prize for the first organ transplant, kidney transplants. They received it together. And you know how the bone marrow transplant started in India? The first bone marrow transplant was done in Tata Memorial Hospital in the year 1982. And who was the driving force behind it? It was Sunil Dutt. Sunil Dutt's wife had blood cancer. Nargis Dutt had not blood cancer, he had some other cancer, but he was at the forefront of trying to get newer technologies related to cancer in India. And he was the one who forced Dr. Advani and other doctors in Tata Memorial to go abroad, learn this technology, and come back. And he actually funded some of the drugs for the first patient who underwent this treatment. And fueled by him, he actually made a movie called Dard Ka Rishta. If you've seen it, it's available free on YouTube. Yeah, so see that movie. It's pretty nicely scientifically explained. You see that movie. And that movie came in the year 1981, and in 1982, TMH did the first transplant in India.
Wow,
but now we do a transplant.
What an amazing trivia.
Yeah. Now it's common. We do a transplant almost every week. Last year we did about 115 bone marrow transplants. So it's now pretty common.
Got it. And then moving to the more advanced technologies, gene therapy,
Yeah, yeah.
so on.
Yeah, yeah. So, the problem with bone marrow transplant is that it's very toxic. There's a lot of collateral damage. It's like you're planting an atom bomb inside the bone marrow, destroying it, and trying to put somebody else's unnaturally trying to, fool the body, right? You're putting somebody else's cells in it and trying to make it sit there. So it's an unnatural technique. There's a lot of collateral damage to the patient. It has a certain amount of mortality as also. So it's a dangerous treatment. So you want to look at safer treatments. Okay, so what are the safer treatments? So, you know, the lymphocytes of the blood, these are the cells which are primed to recognize cancer all the time, and they're constantly detecting abnormal cancer cells and destroying them. Okay, but sometimes these cancer cells can develop mechanisms of how they can evade. They can change their surface receptors so that the lymphocytes can't bind to them, and then they go on to produce the cancer. The lymphocyte cannot attack them properly. So what people have done is, why not train these lymphocytes, to kill the cancer? So what is done is, in something called as a CAR T cell therapy, or chimeric antigen receptor T cell therapy. What you do is, so you have a patient with say a blood cancer, say a lymphoma. The patient's own, and he's failed the regular lines of treatment. Okay, he has to be a resistant case, not fit for for regular treatment. So then his own lymphocytes are extracted from his blood just by that apheresis technique that I just described. You extract his lymphocytes and send them to a specialized lab. There are only two specialized labs in India currently doing this procedure. In the lab, what they do is they change the DNA of the lymphocytes and make them express a T cell receptor, or a receptor which can correctly bind to the tumor antigen. You identify the tumor antigen, and look at the sequence which is going to correctly bind to that antigen, change the DNA of the lymphocyte, and make them then expand them in the lab and infuse them back into the patient's blood. So you've trained the lymphocytes to kill cancer, and once they come in, they see the target, they expand and just destroy the whole target. So in a very resistant kind of a cancer, this is now approved only for lymphomas, certain leukemias, and multiple myeloma. These are the blood cancers where this treatment is approved, not for any other cancer so far. But in these, it can have magical results. But again, about half the patients can be cured with this technique as of now. But as technology improves, you're going to get better and better at doing this. And interestingly, how do you change the DNA? I'll come to that when I talk. Let me just describe what gene editing and gene therapy would be. So how you change the genes. So gene is if you remember in your you have a DNA sequence. In the DNA, there are nucleotides called ATCG. Okay, and there are these nucleotides which make up your DNA, and a certain sequence of that nucleotide. So very, very long. DNA is very, very long, and a certain sequence in it is called as a gene. The gene produces one protein. Okay, it codes for the production of any protein in your body is produced from your genes. So gene's job is to produce a particular protein. Now, if you have, say, a condition such as thalassemia or hemophilia, sickle cell anemia, where the gene that produces hemoglobin is defective, right? And you want to change that gene. So how are you going to go about it? So what you do is you can actually now produce genes in the lab. You make the correct sequence of your gene in the lab, okay, and then you transfer this into a virus. Typically, it's called as a lentivirus. That's the commonest virus that is used. So virus, you extract the DNA of that virus and put this DNA inside it, and then these viruses are infected with the patient's blood cells in the lab. You extract your stem cells, take them to the lab, and infect them with this lentivirus, which contains the correct gene construct. So a virus typically goes in and integrates with the nucleus of the cell that it infects. Right. So the stem cells are now infected with this correct DNA sequence. And how do you make it go in where it is supposed to go? So there are these DNA scissors, DNA scissors, which can you can go in and clip the DNA where you want it to be clipped. Okay, and these are the commonest DNA scissors that uses is something called CRISPR-Cas9, which you may have heard of. CRISPR-Cas9 is a DNA scissor which will go and you train that scissor, you design the CRISPR-Cas9 to go and clip off the DNA, and then this gene will go and stick there, and then lo and behold, you have a gene corrected stem cell. And then these stem cells are then expanded in the lab. And then you again do a bone marrow transplant with that, meaning you give chemotherapy, destroy your bone marrow, and implant these corrected stem cells in your blood. And then they go and start producing normal hemoglobin. So sickle cell anemia and thalassemia today are cured with gene therapy. Similarly, the gene for a clotting factor called factor 8 and factor 9, these are if you have deficiency of these, you have a condition called hemophilia, which is where the patients have a miserable life. They just keep bleeding all the time. Little bit of injury, spontaneous, some moments here and there they bleed. So that's because these clotting factors are deficient. And similarly, you can correct these by by changing the there of course the liver produces these clotting factors. So you've got to make sure that your liver cells will get infected with this lentivirus, and then the liver will start producing the corrected clotting factor, the clotting factor, and that's how you can cure hemophilia. So these are there are various other diseases apart from the blood disorders where gene therapy is known to happen, but the best results and long-term cure is possible in blood disorders with gene therapy. So also there's something called as gene editing, where you can actually there are some there are some genes which produce bad substances which cause disease. You can silence those genes. You just edit, you extract, you just edit the genes, just clip off that gene and allow the DNA to reform. It will join back again, and that gene is edited. So something like that. Sometimes the DNA, that gene, the corrected gene doesn't have to integrate with the DNA. It can just go inside the nucleus and just stay inside the nucleus as a satellite. You have a DNA here, you have a moon, a satellite sitting there, which is just producing its job, doing it. That gene is just producing the substance that is produced to produce. And then again, you can have normal blood. Sounds like science fiction. It sounds like that to me also for all these years. But now there are FDA approved gene therapies. The issue is, one, in the US, if you go and do this, there are very few countries where it's available currently. It's about 6 crores.
Yeah.
Only for the gene therapy, and other costs are different. Okay, that's the cost is a big issue. Are they safe? Yes, they're pretty safe now. They weren't safe for all these years that scientists were trying, but now they are pretty safe. And but now whenever something is very expensive, so CAR T cell therapy, for example, is about 6 crores in the US. But now we do about in our hospital, I do about 1 CAR T every month, and the cost is 30 lakhs currently. It's expensive.
Wow.
Expensive like hell, but still, compared to what it is abroad, India has the cheapest CAR Ts. So that it's magical. It's less toxic. It can cure the patient equally well. Gene therapy, similarly, already our scientists have, in fact, one of my professors, Dr. Alok Srivastava from CMC Vellore, he has produced gene therapy for hemophilia. He's got the vector ready. Everything is done. And there are constructs for sickle cell anemia, thalassemia also. They're all ready. The vectors are all ready. But the problem is to get them to, they're expensive. In India, they might still cost something like 50 lakhs or so. And who's going to pay for all these? The sickle cell anemia patient. India is a poor country. Most of patients are still poor. They can't afford. And if government has to take up, these technologies and they've got to fund it, it's a huge burden, as we know. And also, commercially, if you want to make it viable, you have to ask something like a pharma company to take over, right? But currently, the scientists are trying to convince pharma companies, get out of just producing drugs, aping foreign drugs, and producing them and making money, go into this kind of technology. But nobody's willing to, a little scared to move into a technology that's completely different.
Right.
You don't know how well it'll work, how many patients actually going to do it. So to put in so many resources to produce such a difficult, an innovative technique is also a little difficult for them to digest right now. That's where we are right now.
Yeah.
Hopefully, in future it will become cheap.
So fascinating. Yeah. I mean, 2 interesting pieces of trivia along the lines. One is there are quite a few people who are given credit for CRISPR, but one of them is this Professor Jennifer Doudna, who lives not very far from here, from where I live.
Oh, really?
Yeah.
Oh,
wow. She's a Berkeley professor.
Yes, I know Dr. Doudna.
Yeah, and so because I was there when I graduated, she had just started as a professor there, and she lives very close by. So that's an interesting piece of trivia. And the second one is You were talking about how expensive treatment is. There is
Yeah.
a disorder, a genetic disorder called spinal muscular atrophy. And
Yes.
that in the US, there are
Yes.
three pharma companies that
Okay.
create the gene therapy for it. It's a one-time shot,
Okay.
$2.1
Yes.
million per baby. That's,
Wow.
whatever, like 18,
Yeah.
16,
Yeah.
18 crores. It's ridiculous.
Yeah, so our hospital also, through crowdfunding, it got one or two spinal muscular atrophy gene therapies done. So we've also done it. But then, as I told you, it's just one or two odd cases because it's very difficult for patients to afford.
Right, right.
Yeah.
Well, I know we could keep talking. I've not even gone through half the questions, Samir, but since we're running out of time, I want to quickly get
Yeah.
some. There are quite a few questions from the audience. What can be the cause and treatment for children with very small red blood cells? Is the first question from the community.
Typically, iron deficiency anemia, commonest reason, very common at 1 year of age, and subsequently in growing children when they don't, when they're based on a milk-based diet that doesn't contain iron, they need to quickly switch to a better diet. And commonest cause of low small RBCs is iron deficiency and also thalassemia.
Great. I think given what you said, it's worthwhile. If you're seeing those things, please go talk to your doctor and see if they should test for thalassemia. Uh,
Yeah.
Revati said, very, very informative. Is it good for vegetarians to take vitamin B12 supplements every day?
You don't have to take it every day. The thing is, it's a vitamin B12 is non-toxic. If you take it in large amounts, also it gets excreted through the urine. It doesn't cause harm per se. But I would say that if you could just take a few shots of tablets of B12 every few months. I would say very randomly. If you ask me, I would say take one tablet a month for once in a year, something like that. If you are otherwise deficient.
And those are very high, this thing, right? High capacity. Like, what would the.
Yeah. 1500 milligrams of B12 in one tablet. There are sublingual tablets also. You put it under tongue, it bypasses the gastric, acid, just gets absorbed directly from the tongue, from below the tongue. So these are also available. Yeah.
Sachin said, red cell distribution width as a marker of mortality.
Let's not get into that, Sachin. It's very complicated, and I know what you're talking about. But for the general community, maybe it's too complicated a question. It's too medical a question.
Yeah.
Red cell distribution, which is basically. No, let's not get into that.
Yeah.
I'll talk to you on a different platform,
Yeah.
face to face.
Very informative session. Kedar said, can you comment on appropriate timing of blood tests beyond standard fasting, PP? Example, how cortisol measurement or dengue test is dependent on timing. Also, what to follow and avoid before doing blood tests for accurate results.
That's a very, very broad question, and it's not. I can't answer it because it varies from test to test. So a blood test. Remember, I'm a hematologist. I'm not, a lipidologist who can advise. Of course, I can tell you a little bit about it, but it varies so much from the test that you're asking for. So if it's a hemogram, you can do it any time of the day. If it's a lipid test, you got to do it on a 12 to 14 hour fasting. A1C can be done at any time of the day. Cortisol has to be at 9 a.m. and 4 p.m. because that's the time when you have a high cortisol and a low cortisol. So it depends on the test that you're looking at. So it's very difficult to answer that question, unfortunately, Kedar.
Yeah, no, that makes sense. And he also said, can you comment on likely at-home reliable tests beyond typical sugar measurements? Are these at-home tests for the various markers useful?
No. There are very few at-home tests. The most reliable would be a glucometer. Also, there are, these, you can check the hemoglobin at home, but, you won't need to do that all the time, right? So I won't recommend that you have something like that at home. Apart from a glucometer, I can't think of a test that you should have at home and that you would want to check so frequently where you need to have a machine at home to do it.
Right. What is the success rate of BMT? Is a question from Sujata.
It depends on the condition. If you have a child with thalassemia, pediatric patients do much better than adults because their ability to tolerate treatment and accept, their immunity is naive. So you can easily fool it and make it accept somebody else's immunity. So it can, the success rates can be up to 90%. But if you're dealing with the, so if you're dealing with the bone marrow failure, the chances of cure are about somewhere around 70%. If you're dealing with the blood cancer, depending upon what good of matches, how bad your disease was, between 40 to 70% is the chance of cure. So it varies on that, on what you're dealing with and how the patient's condition is. If you've got a very frail patient who's elderly, your chances are low. If you've got a young, robust patient, your chances are high.
Yeah. Hiram's question: do statins lead to lower B12 levels?
I know of metformin, which is not a statin, that leads to B12 level, the low B12 levels. Maybe in your next talk with Rashida, she'll tell you about statins, but I'm not aware of that.
Right. Right. I think that there are questions from others. Sweta and Kumu, your questions have been answered, so they show up in the notes, so you can see things like what are the cause of bad B12 or D deficiency. That's been covered, so we'll make sure they show up in the notes. Tushar had a comment, very, very informative session. Appreciate the simplicity in presenting the scientific details. Many thanks. So I think we need to let Samir go. He's probably getting a ton of messages. He's a very busy doctor. And Samir, thank you so much. Very informative, very insightful. You really simplified it, and you can see the love you're getting from the community.
Thank you.
But thank you so much. It really was special. And as I had promised people, it was going to be interesting, and you made it all the more so.
Well, thank you a lot. I also enjoyed this session. This is the first time I've come on such a platform. So, but thank you. I didn't know how it would go, but thanks a lot for the appreciation.
It was great. Thanks, Samir. And thank you all. Good day, good night.
Thank you.